Hello, welcome. I'm Dr. Hao. I'm a Division Chief of Nephrology, Huashan Hospital, Fudan University. And today we're going to discuss CKD MBD, an important part of CKD management. And today we're very pleased to have our co-chair of KDIGO guideline on CKD MBD, Dr. Markus Ketteler. Dr. Ketteler is also a professor of medicine and division chief of nephrology, Clinical Coburg, Germany. He is also a chairperson of EREDTA at the Ministry of Office. Hi, Dr. Ketteler, welcome. And do you want to say a few to our audience?
I also thank you for your kind introduction first. Mm-hmm. And welcome to everyone listening to us today.
All right, great. And we also noticed that since 2009, the first release of KDIGO guideline on CKD MBD, and some new studies has finished, published, and some new information has released. And I also noticed the KDIGO guideline workforce has some updates for public review, and I guess the public review has been finished. And can you just share with us some key messages of these updates of CKD MBD management?
Yeah, thank you for your question. I would say maybe the key change in the update of the guidelines, which is a selective update, were looked at more closely now, is about the increasing concerns with a positive calcium balance and the potential harms of calcium during the treatment of CKD MBD. This is reflected in several of these guidelines. Another point is possibly that there are differences between the stages of CKD. So the new recommendations differentiate in a way between the early stages of management and the late stages. So the management, especially of, for example, hyperphosphatemia in dialysis patients. Third, a small item is maybe that we realize that bone density measurements are or may become useful also in the CKD population. That was not thought to be the case in the 2009 guidelines. And concerning the management of secondary hyperparathyroidism, there is now some study evidence that the too early use of active vitamin D metabolites or derivatives is potentially not leading to the goal that we anticipate.
All right. Can you just a little bit in the detail, like what kind of updates on particularly concern of the positive calcium balance?
Yes. One point is that the new guidelines suggest a new target range for calcium levels. That means that in the previous guidelines we had the case that the normal range of calcium was thought to be appropriate. The new guidelines now say avoid hypercalcemia. And this, of course, means that in the low range of calcium, so with hypocalcemia, there is a little bit less concern. And the reason comes actually from a large trial on secondary hyperparathyroidism in dialysis patients from the EVOLVE trial, where it was shown that with the lowering of PTH, which is what we want to achieve, we at the same time also sometimes have low calcium levels, which are usually asymptomatic. If we would have stayed now with the previous guidelines, each patient with an expected drop in the calcium below the below the so-called normal range would have had to be substituted with as much calcium to become into the normal range. And this, under the treatment with the calcium mimetic, might be even a bit harmful because this would lead to a very positive calcium balance. So it's now a bit an individualized decision whether there is harmful or symptomatic hypocalcemia without the treatment of calcium mimetics, or if calcium mimetics lead to some degree of hypocalcemia, which now can be tolerated.
All right, thank you. So as I understand that the old version of guideline says like keep the calcium level in the normal range. Yeah. Now it looks like we do not want like a the high level, but the low level is a little bit like a tolerated less a concern. Particularly in the dialysis population with calcium mimetics, and if the calcium is a little lower, it should be okay, yes. or it's kind of tolerant.
Yeah, it's even in the case of calcium mimetic treatment, it probably is a sign of effective therapy because the calcium might move into the bone where it belongs.
Right. But also like a pre-dialysis. And because we often see in patients like a stage 4 CKD and we have like a hypocalcemia. And what do we think about this? Should we treat them or should we just leave it as it is?
Yeah, it's more difficult in the pre-dialysis patients because there you don't have, for example, calcium mimetic treatment. There I would say that it depends on the PTH situation. If you have a patient with a low calcium and a steadily rising PTH or already pretty high PTH level, you should probably give calcium to the patient. You should probably give even some degree of active vitamin D to the patient. But if the PTH is slightly elevated, which is possibly an important adaptive response, and the hypocalcemia is mild, I would not be worried too much. So it depends on the interaction of these levels. And I think this is maybe another important result of these new update of the guidelines, because we now say with a new guideline that we always should be aware to look at PTH, calcium, and phosphate at the same time and consider them together. Because if you move one target, you might move the others too. If you lower phosphate, the PTH might go down as well.
Right.
On the other hand, if you have a too low calcium, the PTH might go up. And we know from a good study from Geoff Block, published in 2013, that for example, a high PTH is in dialysis patients only a mortality predictor if at the same time phosphate or calcium are also derailed.
Right, and actually this comes next. The point is we should pay more attention to the outcome instead of single chemical values. So we should take phosphate, calcium, and PTH together to evaluate this patient. What should we do? So, okay, great. Or a positive calcium balance is a big concern we actually just mentioned. And in our clinical practice, like for example, pre-dialysis patient, what's the recommendation of this preventive phosphate-lowering drug or binders?
Okay. Yeah, let's say the new standpoint from the guidelines is that a preventive phosphate lowering, so treatment of phosphate with phosphate binders, for example, in patients who are still their phosphate in the normal range, we don't have data that support this. If a patient rises up with the phosphate above the normal range, and this is, for example, proven by 2 consecutive levels that are hyperphosphatemic, treatment should happen. But in this case, we learned from a study published in 2012 by Block and colleagues that if we use in these earlier stages, for example, calcium-based binders, we might run a risk that there is even an increase of, for example, coronary or aortic calcifications, despite we lower the phosphate, because in these stages, patients seem to be more vulnerable to a calcium load than we anticipated before. This was also supported by a balance study published in 2013 by Hill and colleagues, who showed that even with a rather low dose of, for example, calcium carbonate in these CKD patients, there was a significantly positive calcium balance occurring. So in CKD patients not on dialysis, if they become hyperphosphatemic, treatment is strongly recommended, but with a significant restriction of calcium supplementation or calcium binders, calcium-based binders.
All right. So as I understand, if pre-dialysis, if their phosphate level is higher, probably we should use some kind of binders, and probably it's better to use no calcium-containing binders.
That is currently recommended. Yes.
Right. If it's phosphate is not higher, and probably it's not good idea to use these binders, right?
In this case, you should not you should not use either of them.
Right.
So
right.
You wait until the phosphate gets kind of out of control, and which is an elevation above the normal range, and not before.
Right. Right. I also noticed that you have participated in that Jeffrey Block's study, right? That study look at the calcium binder containing binder and no calcium containing binder, you'll find that with this phosphate binder, there's kind of increased calcification, vascular calcification. So is there any difference between calcium-containing binder and no calcium-containing binder? And as in the study you just mentioned, the patient with a higher phosphate level, probably no calcium-containing binder has some beneficial effect.
In this very early study, where the patients were still normal phosphatemic, so where it was used in the attempt to be preventive,
right.
The calcium-free binders did also not have an improved effect comparing placebo.
Right.
They were just on the same
right.
level as placebo.
Right.
But we saw the damage, the calcification
right.
with the calcium-based binder. And one has to say that in this study, high doses were used. Pretty high doses were used. Because the attempt was to lower the phosphate
level
in the lower half of the normal range, and this succeeded only in very few patients. So the internal regulatory mechanisms are already at play there.
Right. And I also noticed even with some renal function pre-dialysis, and if you reduce the phosphate absorption, and the kidney excretion phosphate will reduce significantly. So it will that's why probably the phosphate balance didn't really change.
Possibly,
So mechanisms not know, right?
Yeah, some we know with FGF23, of course, and PTH. And this is another point concerning the PTH in the pre-dialysis stages, because if we lower the PTH too much, we will antagonize the phosphate clearance.
Right.
This means that if you have a too low PTH in the pre-dialysis stages, the phosphate may come up, and this may be an adverse effect. So it's all about physiology and pathophysiology, adaptation and maladaptation. And so we are still in the beginning to understand the full picture. Right.
Also, you just mentioned this EVOLVE study about calcium mimetics. The calcium lower calcium level can be less concern. And we also know this EVOLVE study published in New England looks like a negative study. What's your comments on this?
Okay. Yeah, that's a very complex question. Because from a formal point of view, if you take it, if the primary endpoint that was designed at the beginning of the study, and this is always for an intention to treat population, if this is not significant, of statistical significance, the study is negative or neutral. And this is for sure the case with EVOLVE. The point is that this study had a few surprising circumstances.
Right.
One was that it was thought that it is not important to age adjust the two groups, because it was thought with 4,000 patients included, this would be in balance anyway. Unfortunately, this was not the case. So if an age adjustment would have been done during the study or prior to the study would be positive in favor for sinacalcet. But it was not done.
Right.
The second difficulty here was that the Cinacalcet was already commercially available, so that in the placebo group, up to 20% of the patients who were assigned to placebo and with intention to treat stayed with placebo, in reality received the Cinacalcet, while there was a dropout in the Cinacalcet group of about 20%. So the groups were a bit mixed to some degree. And this was also not, let's say, intended, but it was, people were afraid of that. So they performed a kind of a so-called lag censoring or more per protocol analysis, where endpoints were only assigned if they were happening within 6 months after a change of these treatments. And in this case also there would have been a benefit for Cinacalcet. And in other predefined secondary post-hoc analysis, there were some potentially meaningful advantages for Cinacalcet.
So yeah, looks like although several issues happened for this trial, but after all this post-hoc analysis and some other analysis, looks like may still have some benefit for this CKD MD population patient.
It looks away a bit like that. And maybe what is more important even is that the EVOLVE trial showed very clearly that Cinacalcet treatment is a very safe therapy.
That's the important issue.
The safety point is maybe even one of the key outcomes of this study, because we don't have such studies with, for example, calcitriol or other active vitamin D analogs, to be honest. So this is something that the nephrologists and we all learned about the EVOLVE study. Calcimimetic treatment is very safe, and this is something one has to continue for thinking about in the future.
Calcimimetics, I mean, in the CKD or dialysis population, and there are several approaches to try to lower PTH levels. So we have a active vitamin D or analog, and now we have a calcimimetics, and so in clinical practice, and so what do you think, and how we should approach these things? Yeah,
I think that then we come back to what we said before, that PTH, calcium, and phosphate have to be considered together. And so to make the decision which is your first-line choice of treatment of secondary hyperparathyroidism, you have to look at calcium and phosphate in parallel. So in any patient where the phosphate is not well controlled, or in any patient where the calcium is normal, high normal, or even high, calcimimetics would certainly be the first choice of treatment, the first line treatment. In a patient where you have a low calcium, or where you have a phosphate under control, calcitriol or the other vitamin D analogs are probably the first line treatment. And what has to be considered here is definitely that you can use them together. So it's relatively powerful to use these compounds together, and you can even, let's say, antagonize the side effects of the one with the other. So these options you have. But I would make my decision quite strongly based on how calcium and phosphate are controlled and how these levels are.
All right. Yeah. Great. So looks like I mean, calcimimetics has some opportunity for vitamin D on board, and probably vitamin D is good for bones also.
Yeah, you have to consider both actions. I think if you then go back to the development of all of this secondary hyperparathyroidism, if you go back even far before dialysis, if you have a chance to see these patients in early stages, and you supplement them, for example, with native vitamin D, if you have the opportunity to do that, you can prolong or delay the development of secondary hyperparathyroidism for years sometimes. So only on dialysis you have to think about what is your key goal, and the key goal is probably in case of progressive secondary hyperparathyroidism to keep the PTH at bay, to block the development of high turnover bone disease. This is your goal of treatment. It's not the PTH level. It's the bone disease that you want to target. And then it really depends on how these other parameters can be controlled by all the means you have. And of course, you have to also consider how to use the phosphate binders here, or phosphate restriction in the diet, or also the dialysis practice, of course.
All right, great, and thank you. And it looks like today we have a very a good discussion, and it looks like here are several messages and or take-home message that I have at least, and one is we should pay attention to the calcium, particularly positive calcium balance, and this probably will not encourage pre-dialysis population like a preventive lowering phosphate, and this is the one issue. And another issue is probably we should look at the patient for PTH, phosphate, calcium, and probably calcification of arteries and altogether, and to decide what should we do to manage this patient. Number 3, and also we have a new drug, calcium mimetics, and this is safe, this is important, and also has some benefit through this sub-analysis or post-hoc analysis showing probably cardiovascular also have some beneficial effect. And at the same time, it will lower calcium level, probably itself is not big concern, or it's less concern. Also have some other chance to use vitamin D and those drugs, and probably we can put them together and for the CKD MBD patient. All right, thank you very much.
Thank you so much.